Hello, everyone. Today we are discussing a hormone that determines whether the body survives stress or collapse under it. So, today our topic is glucocorticoids. If you truly understand cortisol, you understand stress, physiology, metabolic adaptation, and several major clinical disorders. So, let's get straight into it. What about the learning objective of this session? At the end of this session, you should be able to understand, define glucocorticoids clearly, identify their site of excretion, explain their chemistry, half-life, synthesis, and mechanism of action. Next point is describe their metabolic effects on carbohydrates, proteins, fats, and minerals. And finally, you need to correlate the hypersecretion and hyposecretion clinically. This is not just a theory. This is an exam-related and clinically critical topic. So, what are the learning resources you can use for this topic? Chatterjee, Harper, Lippincott, and Satyanarayana. Glucocorticoids. Glucocorticoids are steroid hormones that primarily regulate glucose metabolism. That's why the name starts with gluco. But do not oversimplify them. They regulate carbohydrates, proteins, fats, water balance, immune responses, stress adaptation. So we can categorize, or there are three main glucocorticoids: cortisol, corticosterone, and cortisone. And among these, cortisol is the dominant hormone in humans. When we say glucocorticoids in clinical practice, we mostly mean cortisol. Glucocorticoids are secreted by the adrenal cortex, more specifically, the zona fasciculata. And just to remember the adrenal cortex layers, there are three layers: zona glomerulosa, zona fasciculata, zona reticularis. You can use the GFR, glomerulosa, fasciculata, and reticularis, to remember this. As we discussed earlier, the zona fasciculata is the producer or the main producer of the cortisol, but a very small amount is secreted by the zona reticularis as well. If the zona fasciculata fails, cortisol drops dramatically. As you can see in this illustration, or in these illustrations, all glucocorticoids are synthesized from cortisol. They are C21 steroid hormones. Because they are steroids, they are not stored in vesicles. They are synthesized on demand and diffuse immediately into the bloodstream. This is why ACTH stimulation can rapidly increase cortisol production. No storage, just synthesis and release. What about the half-life and the chemistry of the glucocorticoids? As you know that glucocorticoids are 21 carbon atoms in its structure, Cortisol is the main key player among all these glucocorticoids. Cortisol is the main player, so its half-life is approximately 70 to 90 minutes. Corticosterone has a shorter half-life, around 50 minutes. Half-life matters clinically because it determines dosing intervals when we prescribe synthetic steroids. Let's talk about the potency of these. Cortisol accounts for approximately 95% of the glucocorticoid activity. Corticosterone contributes about 4%. Cortisone or cortisone contributes about 1%. So, from the physiological and clinical standpoint, cortisol is the key player. Aldosterone is a life-saving hormone, while the cortisol is called as life-protecting hormone. Without aldosterone, electrolyte balance fails rapidly. Without cortisol, the body cannot handle stress. Patients who undergo adrenalectomy cannot tolerate even mild stress, so they may collapse and go into shock. Furthermore, cortisol enables survival under trauma, infection, surgery, and emotional stress. Now we move to the most important section, the functions of the glucocorticoids. Glucocorticoids effects on carbohydrate metabolism, protein metabolism, fat metabolism, water metabolism, mineral metabolism, bones, muscles, on blood cells, on vascular response, CNS, and it got permissive action of glucocorticoids as well on resistance to stress. It also got anti-inflammatory effects, anti-allergic actions, and immunosuppressive effects as well. So let's discuss one by one each of these effects. Let's start with the carbohydrate metabolism. Cortisol increases blood glucose. It does this in two major ways. First, by promoting gluconeogenesis in the liver using amino acids. Secondly, by decreasing glucose uptake in peripheral tissues. So, glucose remains in the blood. What would be the end result? That would be hyperglycemia. In case of chronic hypersecretion, can produce what we call adrenal diabetes. Clinically, in Cushing syndrome, patients often present with elevated blood glucose levels. If cortisol level fall, gluconeogenesis decreases. If the gluconeogenesis decreases, blood glucose levels drops. During fasting, this can become life-threatening. This is why patients with adrenal insufficiency require steroid support during stress. Next is the effect on protein metabolism. Cortisol promotes protein catabolism. It breaks down proteins in muscles and peripheral tissues. And the result would be the amino acids are released into the blood. The liver takes up these amino acids and use them for the gluconeogenesis. The consequence would be muscle wasting, negative nitrogen balance, thin limb, and Cushing syndrome. This is why chronic steroid therapy causes muscle weakness. Next is fat metabolism. Cortisol mobilizes fat from adipose tissue. It increases circulating free fatty acids. It also promotes utilization of fats for energy. But here is the paradox. While mobilizing fat, cortisol also redistributes fat abnormally. So fat accumulates in the face, producing moon face, and the back of the neck, producing buffalo hump, the abdomen, center obesity. This pattern is characteristic of Cushingioid appearance. Next is the effect on mineral metabolism. Although primarily a glucocorticoid, cortisol has mild mineralocorticoid effects. It increases sodium retention. It increases potassium excretion. It reduces calcium absorption from the intestines. Chronic excess can cause hypertension, hypokalemia, edema, osteoporosis. So even mild mineral effect become significant when cortisol is chronically elevated. Now let's discuss mechanism of action. Cortisol is a steroid hormone. It diffuses across the cell membrane and it binds to an intracellular receptor. The hormone receptor complex enters the nucleus and binds to the DNA, where it stimulates the RNA synthesis. And that mRNA, messenger RNA, produces enzyme that alter cell function. This is a genomic mechanism, and the effects are slower to start but long-lasting because this is lipid in nature and act by acting on the nuclear receptors, intracellular receptors. Next is the regulation of excretion. Cortisol. Cortisol excretion is controlled by HPA axis. Hypothalamus excretes CRF, that is corticotropin releasing factor. And in response to CRF, pituitary excretes ACTH, that is adrenocorticotropic hormone. And in response to ACTH, adrenal cortex excretes cortisol. And cortisol then exerts negative feedback on both hypothalamus and pituitary. But keep in mind, the stress can override this feedback mechanism. What about the stress stimuli? Those can override this feedback mechanism. Cortisol increases during trauma, infection, surgery, extreme heat, or extreme cold, severe illness, and This is adaptive physiology. Without cold, the body cannot mount an adequate stress response. Now, at the end, let's just integrate. What about the hypersecretion? Hypersecretion of cortisol leads to Cushingoid or Cushing syndrome. Features are hyperglycemia, muscle wasting, central obesity, hypertension, osteoporosis, and the counterpart is the hypersecretion that leads to Addison disease. And the features are hypoglycemia, hypotension, weakness, stress intolerance, and in severe cases, adrenal crisis may be seen. So you always need to connect your biochemistry along with physiology and pathology as well. This is how biochemistry becomes clinically important and becomes clinical medicine. So, to sum up, glucocorticoids are 21 carbon containing structure, steroid hormones derived from cholesterol. Cortisol is the dominant glucocorticoid in humans, and the glucocorticoids regulate carbohydrate, protein, and fat metabolism. They modulate immune responses. They enable stress survival. Excess cause metabolic and systemic complications. And even the deficiency can be fatal. Understand cortisol and you understand stress physiology. Thank you very much. If this lecture helped clarify glucocorticoids in a structured and clinically integrated way, make sure to like the video, share it with your colleagues and students, and subscribe to the channel for more high-yield biochemistry lectures designed specially for the medical professionals and exam preparation. Your support helps us to continue delivering focused, exam-oriented, and clinically relevant content. Thank you once again